thank you for this brief introduction, and you must be thinking that this guy has been working as a head of the chest department, as a otherwise whenever the government sees that who is required, the internalists are there to ready, they are ready to hold the control of any department, and we are in a leading position, at least in SIM, to fight against this COVID-19. So, sir, with the permission of Honorable Chair and my seniors, I will today discuss about the thing which comes to us if we forget about the first lecture. Means if happiness goes away, then this thing will come to our heart and mind. Hypertension. This session is sponsored by Novartis, and apart from this session, we have never taken a lunch from Novartis.
Sir, dinner में realized.
So, just brief introduction. What we are going to discuss here is a global trend. Why hypertension? How does it comes to us? Why to treat? Why it's important? When to treat? How to treat? And some clinical data. So this is really, hypertension is a global trend for us, and almost 40% of population is estimated to have this problem. And this problem is rising with as the life prediction of the human being is increasing. And it is the primary cause of the cardiovascular accidents and the deaths. If we estimate by 2025 what's going to happen, it's increasing a lot. In future we can see this as a epidemic, and I will say this is at the moment, this is a great burden for us, but it will be even more severe at the 2025. Just you can see, just in South Asia, you can see by 81% the increase from 118 billion to 214 billion. So 81% increase after 4 years, you can see. Same situation is in Pakistan. In Pakistan, 37 to 40% of adult population is said to have hypertension. Now, why it should be treated? Because it's not blood pressure, just डॉक्टर साहब ये तो just tension की वजह से हो गया है, डॉक्टर साहब ये तो आपके पास आके हो गया है. You cannot deny this thing. You have to tell our patient that if you are not going to treat this, what can happen. So different cardiovascular complications, strokes, renal diseases, retinopathy, peripheral vascular disease that includes peripheral lung disease, erectile dysfunctions, and cardiac related problems. These are complications of hypertension. In testing data from different studies, increasing the blood pressure increases the risk of death from stroke. The well-known multiple risk factor intervention trial, it shows. Another interesting data, every 20 millimeter of mercury in systolic and 10 millimeter of mercury in diastolic blood pressure doubles the cardiovascular risk, mortality risk. And you can see here, it starts from 115 or 75. It's not always saying that blood pressure is 155, then if it's more from 155, it's the same thing. If you can say that if someone having normal blood pressure and he becomes hypertensive in the lower zone, even then the risk is doubled. Second is a bit positive side, blood pressure reduction of 2 millimeter of mercury decreases the risk of cardiovascular events by 7 to 10%. How does this happen? Why it comes to us? On one side, yes, there are many factors. Those are social factors, psychological factors. Those can contribute. But ultimately, they take some pathways. They have to take some biochemical and physiological pathways. And these are sympathetic nervous system. We were talking about the chronic stress. Sympathetic nervous system mediates it. Then renin-angiotensin system. And then total body sodium. Renin-angiotensin system, it basically is our friend. But whenever we are under constant stress, then it does not remain friend for us. Then it focus, and chronic activation leads to hypertension, volume overload, structural changes in the vessels, and fibrosis and thrombosis. And the system, angiotensin 2, has multiple vascular effects. And these vascular effects, I'm not using this laser pointer because I'm a chair. Sometimes it can cause, it's not safe to use if they are very close to that. So it causes vasoconstriction, inflammation, remodeling, and thrombosis. These are some mechanisms for my juniors that those can lead to the permanent changes and different pathologies in the different organs. And these pathophysiological effects of angiotensin act via AT1 receptor stimulation. And you can see right from vasoconstriction, aldosterone, just to name the physiological abnormality there, this angiotensin 2 acts via AT1. Now, if we inhibit the renin-angiotensin-aldosterone system that because of chronic stress give rise to problems and pathologies in the different system, if you block it in any way, it's going to help us in preventing the complication. If you stop the renin, the same thing. If we start the conversion of angiotensin to the angiotensin 2 by using AC inhibitors, we will get the same result, and same results can be obtained by blocking the AC receptor blocker. So, using these mechanisms, you can decrease the inflammation, vasodilatations, and vascular hypertrophies, arterial stiffness, and vascular remodeling. So this gives rise to the decrease in blood pressure. On the other side, reversal of the left ventricle abnormalities, fibrosis, and decreased sympathetic activation all give rise to decrease in heart failure and heart-related complications. These are the pathophysiological mechanisms involved, and there are secondary causes of hypertension. You know everything about it. One underdiagnosed and under-considered is obstructive sleep apnea. So for my juniors, always ask person for sleep apnea. You need to know how to diagnose the obstructive sleep apnea, and there is a strong association between it. Otherwise, you know, you can. Everyone is practicing as part of your training that how to rule out secondary hypertension. When to treat? Should every person should be treated? A few words about before labeling a patient hypertensive. Professor Javisa was discussing about the ambulatory hypertension, and today what is being practiced here, I'm talking about most of us which in therapies we are doing, some of the consultants, they are really doing what's needed. But nowadays, think about the automated office blood pressure monitoring, because you know the presence of person and the non-digital use, they can affect the blood pressure control, the blood pressure readings as well. This is something very important. And even if it's not possible, if you are taking blood pressure in office, that's not automated, 3 readings should be taken, and 3 readings 5 minutes apart with all the protocols, and the first reading should be discarded. And the average of second 2 should be used, average of that. And that's why very often you must start, the doctor साहब मेरा घर पे तो ठीक रहता है, यहाँ के क्यों बढ़ जाता है? This is the way how most of the white coat hypertension you can avoid. Another thing that's very interesting and important is मुझे मेरा blood pressure तो मैं डबरा जो तनु आया सी उधर सही चल रहा है, उधर साल में भी blood pressure खराब कर छोड़े. So this is actually very important. The calibration of the BP apparatus is very important. We may be very good doctor, we may be knowing all the guidelines, but if the BP apparatus is not well calibrated, it can create a lot of problem. I have seen in a tertiary care unit, this is important to share, this is very important, happened with me, and in a tertiary care hospital, in a private tertiary care hospital, in a ward, several of the patients, those were admitted for preeclampsia, and one of those patients was my wife, and really all the persons I saw that they are with preeclampsia, everyone was saying that we were not having blood pressure, and I don't know what happened, and same was my feeling that why this happened. So I got an opportunity to check their blood BP apparatus and with my own one, and there was an error of 30 millimeter of mercury. And then I conducted a study in Karachi in different clinics, including tertiary care hospitals. There was significant difference. There was almost 30% of the, if I remember, this is 15 years back, this was published in the Heart Journal. There was large number of the BP apparatus, those were out of order, those needed calibration. Even some of them were having error of 30 millimeter of mercury. So we have to be careful how before diagnosing, we have to keep these technical things in our mind. So blood pressure targets in various guidelines are different. Recently, I will discuss one of those, not to confuse further, that Alberta Heart Associations and American Heart Association and American College of Cardiology. The hypertension is classified as a, if the systolic blood pressure is more than 130 and diastolic is more than 90. So there was a term pre-hypertension, now it's replaced by elevated BP, and if someone has got blood pressure of 120 to 129 systolic blood pressure and less than 80 millimeter of mercury diastolic blood pressure, this is pre-hypertension. And then previously there were stage 1 hypertension and stage 2 hypertension. They have relabeled the stage 1 hypertension is blood pressure between 130 to 139. And stage 2 hypertension is 140, if more than 140, and diastolic is 190. The difference between two is if stage 1 hypertension is with complications like coronary heart disease, kidney heart disease, and if their risk for heart disease and the stroke using the arteriosclerotic cardiovascular risk factor calculator is more than 10, the treatment should start it. And in stage 2, if you can start along with the non-pharmacological intervention, you have to start with the 2 medicines. This is a change in American Guideline Association. Now, how to treat? First of all, non-pharmacological. Few words about the non-pharmacological. how much non-pharmacological intervention can help us. If a person comes to us with 110 kilogram blood pressure and the sedentary lifestyle, and he promised that let me continue with the lifestyle modification, I will decrease the blood pressure, and his blood pressure is 190 by 110, for example. So it will not be a wise decision, because you see the weight reduction can decrease the blood pressure up to the 20 millimeter of mercury, and the diet, the DASH diet is 8 to 40 millimeter of mercury. This is important, and the role of DASH diet is very, very important. The African tribes, which are those are using just fruits and vegetables, they are not taking any the meat and etc. Their blood pressure is never more than 100 by 80, and cause of death is almost 100% infectious diseases, not cardiovascular diseases. Dietary sodium reduction is also important. It is to be considered seriously. Next slide I will discuss about it. And physical activity at least 30 minutes per day, we have to consider it. But it can decrease only up to 4 to 9 millimeter of mercury blood pressure. And of course, moderation of alcohol consumption is another. Now, can I? One thing I was thinking, that talking management of hypertension in front and with my all senior colleagues, probably we have to highlight those things. Some of us are really among the policymakers, they are heads of institutions, they have got their voice in media, they are opinion leaders, they are leading many schools of thought. So I want to share with them, if we can think about it. Salt restriction is, we have to think on a larger scale. Because if you say that just to stop taking salt, reduce your, it's not easier. Because there are other forces. Just look at, can you stop your child to stop taking this fast food? Really, if I say for me, no, I cannot. Because the peer pressure, because the media, this all stuff is compelling to other side, and there is no regulatory authority on that. So only we cannot do anything. अगर सिर्फ पास करने से इनकलाब आ जाता तो मौलवी हज़रात कितने अरसे से बातचीत कर रहे हैं लोगों से, कुछ बहुत सारी तब्दीलियाँ आ जाती. सिर्फ नसीहतें करने से शायद नहीं बदलेगा. You have to do some regularities, changes as well. So one technique, the Finland has used it very successfully, and in UK it's being practiced. This is the traffic sign spot. If you on your you might have seen, for example, you take a well-known chips packet, very colorful, but the salt content will be on the back side. And who knows what is the content? Any one of us who knows the Lay's content of the Lay's salt content? None of us. So how to know it? And how a normal person can know it? So in UK it is being practiced now. They have decided two things. One thing is that they will reduce this salt, not immediately, but they will reduce the salt but 10 to 20%. This is the level that cannot be appreciated by human taste. So this will be done after every 2 to 3 years. So within 5 to 10 years, the nation will be okay with the national taste. And the salt is, you don't need to pay money. In multinational companies, को खर्च नहीं करना होता है, salt is मुफ्त का. So just they will put it and इसको tasty बना देता है. So उसमें यही इस तरह का स्टफ है, वो जैसे कहते हैं उर्दू में घी बनाए साल बड़ी लोगों का नाम, तो ये वो सारी स्टफ डाल देते हैं और वो टेस्टी बन जाता है। घर में आप बर्गर बनाएं, इतना मज़ेदार नहीं बनता, चीज़ खूब बाहर से आता है बन के, तो बच्चे इसीलिए बाहर का बर्गर पसंद करते हैं। सो दिस इज, और फिर क्या करें कि कंटेंट जो चीज़ों के हैं, आप जैसे रेड है तो इस लिखा होगा हाई सॉल्ट, अगर येलो है तो बॉर्डर लाइन, एंड लो सॉल्ट मीन्स ग्रीन। So even a person who is not literate, who does not have knowledge about medical recommendation, he can see, yes, this is the amount that's needed, there's a good amount of salt. So if we persons, we can raise a voice and we can contact the food authorities that rather than just labeling the content that's of no use for a layman, we can practice such thing. It will create a lot of difference for our future. What's happening there? मोहसिन साहब पता नहीं है या नहीं, ये चले गए, उनके लिए मीर का ये शेर लाया था। होता ये है कि दवाइयाँ मरकाई है। आपने कल पंजाबी के कई शेर सुनाए थे, तो मैंने कहा कराची से आया हूँ, मीर का एक शेर ले आऊँ। तो वो we are talking with a very official that how much money is going for cardiovascular, cardiometabolic drugs. So the amount is really more than 50 billion rupees per year जो बाहर जाता है। और जो फूड बाहर से आ रहा है, उसमें हमारे पास ये जितने भी कोल्ड ड्रिंक्स हैं और ये फास्ट फूड चेन है, वो इसके मुकाबले में वो भी इसके ज़्यादा है। तो पैसा जा भी रहा है, वो हमें खिला भी रहे हैं, ब्लड प्रेशर होता है, फिर दवाइयाँ खिला के आते हैं। तो इसीलिए तो और हम दोनों उनके साथ दे भी रहे हैं, पैसे दे भी रहे हैं। सो मीर क्या सादा है, बीमार हुए जिसके सबब उसी अवतार के लौंडे से दवा लेते हैं। सर ये तो देख रहे हैं आप लोग,
हम हुए तुम हुए कि मीर हुए।
AC receptor blockers, inhibitors, diuretic beta blockers, centrally acting antihypertensive drugs and vasodilators. Few studies to be reviewed, and then it was shown that 33% normalized with the one agent, but 33% needed 2 and 33% needed 3 agents. Some clinical data about the AC, we talked about the AC receptors, blockers and the angiotensin receptors, angiotensin inhibitors. So valsartan is an effective, some few studies I'm going to share with you. Valiant study that shows in the after myocardial infarction, the valsartan was compared with the captopril. The results were the same. In value study, the heart failure events in patients treated with valsartan was lower than as compared to the amlodipine. In the value study, valsartan-based treatment reduced the development of new onset atrial fibrillation compared with the amlodipine. Valsartan significantly reduced morbidity and mortality in patients with congestive heart failure. You know, well-known Valhalla study. In the same Valhalla study, addition of valsartan to standard heart therapy has positive effect on left ventricular structure and function. And then novel study, valsartan was significantly more effective than amlodipine in reducing urine albumin excretion. And the same significantly higher proportion of valsartan treated patient returned to normal albuminuria by week 24. And then one meta-analysis showed that dose-dependent systolic pressure reduction with valsartan and valsartan hydrochlorothiazide. You can see that this is very expected that you increase the dose and there will be a smooth decline in the blood pressure. And the benefits of triple therapy show that the persons who are not benefited from the two medicine, then they benefited from the triple medicine. And then few advantages of fixed dose combination. Obviously, this is a sense that if you take single dose medicine and the fixed dose combination, it's easy to take it. It is patient, it's convenience for the person. Tolerability becomes high. Then compliance is very important, and the compliance also becomes very high. one thing is important talking about the compliance. Before prescribing your medicine, we should know the sharing of decision. The sharing of decision is what you are gonna prescribe to your patient. It should be shared with the patient. If, for example, a medicine is given twice a day, and patient की कुल तनख्वाह महीने की 18,000 है, और आपने कहा कि मैं 1 से 1.5 दवाई दूंगा, एंड वो उसको कंप्लाइंस बढ़ जाएगा, वो उसकी कॉस्ट उसकी हो जाती है 12,000 रुपये, बाकी बच्चों को खिलाने के लिए उसके लिए 6,000 रह जाएगा. So if you make unshared decision, it is unfair decision. So patient's involvement is very important. You have to think that patient जो है के लिए appropriate क्या है, and this is customized report. So telling just one guideline to everyone and applying one guideline to every person is not a very appropriate thing. So think about it. Cost is very important, and overall BP control was seen that it was the control was good with the fixed dose combinations as compared to the monotherapy. And similarly, adverse effect associated with the use of fixed dose combination versus fixed dose, there was a difference, and especially it was seen that peripheral edema with amlodipine alone and then amlodipine combination with the valsartan, there was a significant difference. Summary. So these were few studies related with the valsartan and the drugs affecting the angiotensin and system. In summary, the hypertension is a global threat. We have to think about it. Prevention is always a responsibility of everyone, including stakeholders, media, policy makers, and all the health professionals. Prevention सबकी responsibility है, and हर कोई अपनी जगह पे क्या काम कर सकता है ये हमें सोचना है. अगर मैं आज नहीं इसके लिए काम करूँगा, ये कल मेरे बच्चे मेरी आइंदा जनरेशन को बुरा अफेक्ट करेगा. And then AC receptor blocker breaks the vicious circle that increases the blood pressure. And last one is treatment should always be customized. अगर हम चाहते हैं हमारा पेशेंट कॉम्प्लिकेशन से बचा रहे, तो शेयर डिसीजंस, ये हम लोग मैं बल्कि कॉलेज ऑफ फिजिशियन के भी स्टेज होल्डर से अगर बैठे हों, तो हमारे पास इस चीज़ को थोड़ा सा कम दिया जाता है कि शेयरिंग ऑफ डिसीजन, कि आपको क्या पेशेंट को देना है, तो पेशेंट शुड हैव इक्वल राइट टू शेयर इट. क्योंकि मुझे ये दवाई सूट करेगी, तो फर्स्ट ऑफ ऑल एवरीथिंग should be told to the patient, and that patient should have right that okay, I accept this one, but you have to tell everything. This is a new, not a new spec in our Canadian practice, but here we need to practice. So thank you very much.